All right, so good evening once again, and we are grateful for your participation. Today is the 6th of our CPD program, and today we are glad to have with us Dr. Gifty Boateng. So Dr. Gifty Boateng is currently the head of the Public Health Reference, the National Public Health and Reference Laboratory located in headquarters in Korle Bu, and the coordinator of the Public Health Laboratories in Ghana. And she has over 18 years technical experience in medical laboratory diagnostics and laboratory system strengthening. She holds a BSc in biological science from the Kwame Nkrumah University of Science and Technology and PhD in public health. And she's a certified field epidemiologist and a public health specialist. She's also an International Federation of Biosafety Association certified professional and has facilitated many training sessions, including biosafety and biosecurity, quality management system, sample management, setting up of PCR laboratory for COVID-19 testing. She's also a member of many health policy and guideline committees and has also served as a lead in the drawing of the National Health Laboratory Policy and Strategic Framework. She's also a member of the guideline for National Integrated Specimen Referral and Transport System, among others. And so today we have Dr. Boateng presenting on biosafety and biorisk in medical laboratory. Dr. Boateng, you are welcome, and over to you for your presentation.
Thank you very much, Dr. Kwashi, and good evening to everyone. And then can I be permitted to share my slides?
I think you are co-host, you have the right to.
Okay. Can you see my screen, please?
Yes, please.
Okay. Okay, so thank you once again, and then good evening to everyone. So my task this evening is to have an introduction to biosafety and biosecurity management. And therefore, when we put it together, we are talking about biorisk. So we want to understand it. And so at the end of this session, we'll be grateful if all of us could be able to make biorisk management, distinguish between biorisk management terminology such as what is biorisk, what is biosafety, what is biosecurity, what is the risk management system itself, and then their importance. We should also be able to discuss the concept of risk associated with biological agents, and then to know the levels of biosafeties that we have and their significance in the work we are doing. And so as a way of introduction, when we say biorisk, what do we mean? This is an effective management of all the risks that are associated with us. And we, the lab people, normally the risks that are associated with us include infectious agents, not the agents alone, but their toxins as well. Normally, we are only interested in the agents, but we don't concentrate on the toxins. So how we effectively manage these agents we work with and their toxins is what we call the biorisk management. And normally it will include our practices and procedures. The practices that we have in the lab, the procedures, where we ensure that there's biosecurity, there is biosafety, there's what we call containment of these infectious agents I've talked about and their toxins. Therefore, we need to understand when we say biosecurity, what it means, when we say biosafety, what it means. So we'd want to move on to the terminologies. We want to start with biorisk. So when we say biorisk, In simple terms, it is the risk associated with biological materials. And then you would want to find out what is a biological materials. These are the agents, they are toxins and allergies that I've talked about earlier on. But we have a principle ISO guidelines when we are talking about biorisk management. And that is the ISO 35001, 2019. So anyone who wants to be well-versed in the issues of biorisk, you need to have this document. And how do they define biorisk? It is the effect of uncertainties expressed by the combination of consequences. And where are these consequences coming from? They come from the biological materials we are working with. And the likelihood that you are going to be exposed to these agents is what we are talking about as biorisk. Also, in simple terms, somebody will say that biorisk is biosafety and biorisk. When you are able to effectively manage biosafety and effectively manage biosecurity risk, when you put the two together, then you say it is biorisk. So that is what it means. Please, this is an adult conversation. So as I go on and then you want to ask questions, you can kindly do so that it becomes engaging. So we are saying that biosecurity and biosafety risk will become biorisk, and we know what it is. So what is biosafety? When we talk about biosafety, these are the practices, and we should take note of that, the practices, the controls. So we'd have to know what these controls are that we employ to reduce the risk of unintentional exposure or release of these biological materials. And this is according to the ISO 35001. So we are doing our normal work. We are using practices to work. We have controls that we are putting in place. Anytime that we are working unintentionally, we are being exposed to biological materials. So all the things that we will do to make sure that we reduce this unintentional exposure is what we call biosafety. We also will deal with the WHO manual, the 4th edition, and I hope all of us have it. This document is free online. It also explains biosafety as containment principles. Emphasis, containment principles. Technologies. So you do have to know what these technologies are. Practices again. So he's talking about 3 things: containment principles, technologies, and practices that we implement to prevent unintentional. So the unintentional is also here. Exposure to biological agents or their inadvertent release. If you look at the 2 definitions, these 2 are not different from each other. The first one is talking about practices and controls, which when you put the 2 together, you are going to get the containment principles, the technologies, and also the practices. So these are 3 areas or fundamental areas that we need to know when we are talking about biosafety. And that is what we are going to use to define the biosafety levels that we have in our labs. We are going to look at it in terms of our containment principles, in terms of the technologies we use, and then in terms of the practices. And when we put these 3 together, it helps us to define our levels of biosafety. Then we want to know what is biosecurity for a lab person. Let me also state here that, hello.
I think there's a hand up. Raymond wants to ask a question.
I can't see from my side, so please coordinate for me, I beg.
Raymond,
please, you can go ahead. Raymond, please, you can go ahead and ask your question. 2 participants raised their hands. So please, Solo, please coordinate that part for me.
Elizabeth, kindly ask your question.
If she's talking, we can't hear her, please. Okay, so they can type in the chat box so that you can read for us to address for them.
I think that will help. Thank you.
Okay, thank you too. So we also want to know what is biosecurity. Let me state here that biosecurity is defined by different people. If you talk to a GMO person in terms of biosecurity, their definition will be different. If you talk to a veterinary officer to describe biosecurity for you, they also give you a different definition. But for we, the lab, when we talk about biosecurity, these are practices and controls, again, that we employ to reduce the risk of theft, loss, misuse, diversion of intentional. So that is the difference here. How do you make sure that the biological agents you are working with, intentionally, nobody picks them to misplace it, to steal it, to misuse, to divert it for any unauthorized release? It is important. We have a lot of agents we keep in our labs. What are the practices and controls that prevent anyone from stealing it, including we, the lab staff? What are the controls and practices we put in place to make sure that nobody steals it, nobody diverts it for any use? If I don't like you in the lab, how do my system make sure that I don't use cholera to affect you or to introduce this to your food or any of that sort? So that is the difference. So for biosecurity, intentionally somebody wants to use it for something bad. How do you put in practices? How do you put in controls to prevent that? For biosafety, as you are working unintentionally, we are being exposed. So how do you put in practices, controls to make sure that the unintentional releases are, we the staff, are protected? We come to the purpose. So you see the two ring sides. I'm talking about practices and controls. These are the measures we put in place to control either biosafety or biosecurity. And as you can see, we have the engineering controls, the procedures we do, all these have mixed them. But in all of this, there are some intersections of the things that when you do, you'll be handling biosafety, and some of them when you do, at the same time, you are handling biosecurity. Some of them are different. If you take something like fixing cameras in your lab, that one, when you implement that, is solely working to make sure that you are reducing intentional release by capturing somebody who is stealing. If you go to the other side where you have PPEs, when you put on PPEs, it is more of a biosafety than a biosecurity. But in the middle, there are some intersections. Access control, it serves the same purpose for both. Proper documentation for both. So these are the things, or the controls and practice, some of them that you have to know, the ones that are solely for biosafety and the ones that may intersect. And therefore, when you are practicing in the lab, when you are controlling in the lab, we can use them to work. These are the 5 components. When you implement, you are able to secure the work or the agents you are handling in the lab. And therefore, you are talking about, as soon as you hear security, then it is biosecurity you are talking about. So when you talk about biosecurity, these are the areas you need to work on as lab professionals. Our physical security. How safe are the labs we work in? Are we working in labs that anybody at all can have access, including our relatives? We are so happy to bring in our relatives to the lab. Do we have access control? When we say access control, we can define it in so many ways. Do you have something that tells people that this place is unauthorized, or physically you are preventing people? Any of such is what you have to do to physically protect the organisms you have. Personal security. Do we know the background of the people we are working with? How secure are we working with some lab staff? In some jurisdictions, any lab persons who work in the lab will go through security check. I remember when we wanted to work at the airport for COVID, they had to take our fingerprints at the security. Yes, I can see a hand up, but I can't see the name. Hello, the person can go ahead and ask the question.
Doc, I think the consensus is that flow with your presentation.
Okay.
Yeah.
Okay, thank you. So please then write your questions, and then when we are done, we can discuss. So for personal security, as I was saying, at the airport, when we were testing, we had to take over from Frontiers. We had to be able to give us cars to work there. They needed to take our security issues. So we had to go for fingerprints and all of that because they want to know our background. This is what we are talking about. We need to have the personnel we work with. How secure are we with them? You don't know who the person is. They've been employed. The ideas, in case something happens, can we trace them to their security issues? The material controls and accountability. The materials we have, or the documents, or how well are we controlling these things? The organisms, our biobanks, our fridges, and all of that. Then again, transportation. We are transporting a lot of samples. There are times we take samples, we give to our clients, relatives of patients. We, the public health, we are West. We take samples, we have to transport them to the next level. We are using the VIPs, we are using the OAs. How are we protecting these organisms we are working with in terms of transportation? Do we know what they do with these samples in case it lands in the hands of a bad person? Have we thought about that? Information security. Our lab books, how secure are they? You go into a lab, the books are just anywhere. And as I always tell people, because of cost, we buy the largest of the foolscap sheets, books, where you can get as far back as 3 years data. And these books are left unattended to in our labs. These are the things we are talking about. Information. Those of us who are also having our information, now we are using a lot of LIS. How secure are these laptops we are working on? Some of us are sending results through WhatsApps, through mails. How secure are these? So these are the things we are talking about. So for you to be able to effectively talk about biosecurity, you need to have policies and controls in all these 5 areas. Still on the definitions, now we have known what biorisk is, biosafety, biosecurity. We want to talk about biorisk management. So according to the ISO again, these are coordinated activities to direct and control an organization. And the lab is one. How do we coordinate the activities we do to direct and control what we do in the area of, with regards to biorisk? And I've defined biorisk. So your coordinated activities, does it include how to take care of your biosafety and how your biosafety risk and your biosecurity risk? When you are able to have these coordinated activities in place, then you are talking about biorisk management. When you add the system, then it means that this should be part of your quality management system, where you have a safety issues addressed, and these are being addressed by your policies, by the objectives and the processes to make sure that all the quality management systems you have are in place. So when you do these things, then we are talking about biorisk management. Still to progress. There's something at the top I can't see. So biorisk, bring this back. So now we have talked about biorisk management system, but to be able to approach this kind of system, what do we have to do? Any organization or any facility, lab facility for that matter, who wants to approach biorisk management system, you need to have a system whereby your management system approach enables the organization to effectively, one, to identify, to assess, to control and evaluate your laboratory biosafety and biosecurity risk. So you need to know, be able to identify your biosafety risk. You need to identify your biosecurity risks. You need to assess your biosafety risk. You need to assess your biosecurity risk, your control of biosafety risk, the control of biosecurity risk. So there are 2 things you have to work on, both biosafety and biosecurity risk. You need to identify all of them. You assess all of them, you control all of them. Then you evaluate. When you are able to do that, you are saying that you are approaching it, or you are making sure that you are addressing the issue of biorisk management in your facility. And to be able to do this, in all these things I've talked about, identify, assess, control, and evaluate, it brings back to what we already know, the improvement or continual improvement through the cycle of planning, implementation, reviewing. And we are all familiar with this PDCA in our quality management systems. This is the approach for which you can also use to address biorisk management. You need to know your PDCA, where you plan, you do, you check, and you act. We are all familiar with this. So in the planning phase, what do? That is where you are doing the identification of all the hazards, all the risk in the lab from the pre-analytical phase, analytical phase, and post. You identify all these risks, both biosafety and biosecurity. Then you have to implement. So now you've identified the risk. How do you mitigate, or how do you put in the controls? If you look at our definitions, controls and practices, how do you put in controls, including training and exercises, to make sure that these risks you have identified from pre to post have been dealt with? Then as you implement those things, you need to check. You can only check when you are monitoring, and therefore you need to have a system of checking. Some of these checking will include our routine auditing that we do, sometimes our indicators that we set for the lab, our TATs, customer service. All these things will give us an idea whether we are able to monitor the things we say it is. If you do an audit, you know whether you put in a practices of staff wearing of PPEs. You can only see that we are wearing the PPEs if somebody is monitoring. And this monitoring is just not only observation. You observe and then you put it into writing. So it is done. After you have been able to do this and put in corrective action, you need to act. In the acting here, we are saying that you need to review all the processes you are putting in place. Sometimes some of the reviews, like you want people to use, there should be reduction of needle prick. But as you do your monitoring, you realize that needle prick is on the high side. What are some of the things you can change to reduce that needle stick prick? These are the things we are talking about. So when you do or you use the PDCA, this is the way you can approach and manage all the biosafety and biosecurity risk we will identify in our labs from pre-analytical to post. So then we have to know the key components. We want to approach biosafety, biosecurity risk management in this approach. What are the things that you will need? What are the key factors that can help you to implement that? One, there are 2 key points. The 2 key points are that you need commitment from top management, and then you have to focus on continual improvement. For the top management, we need them because they need to provide us with adequate resources. If, as part of the measures to reduce risk, you are supposed to wear PPEs, we need top management to buy that for us. To work in a biosafety cabinet, we need top management. To make sure that I have eye wash station in case I get spillages and things I need to wash, we need money to do that. If I need staff to do this work, human resource, we need top management. We need top management because we need to prioritize and communicate these policies. We have to write them, and it is top management that have to make sure that they are leading in this area. Somebody will be responsible, but it is a responsibility of the top management to make sure that our policies are in place to address these issues, and also to establish performance of expectation throughout the organization. Top management needs to make sure that we determine causes and incidents, and then we record non-conformities and address them appropriately. We also have to identify opportunities for improvement. And once we focus on continual improvements, we'll be able to address, or these are the 2 key areas that when you implement, you'll be able to solve biorisk management. So why are we worrying ourselves with biorisk? What is the importance of this management we want to know? It is important because lab professionals, we are handling these biological agents, the organisms and their toxins and allergies. We are handling them. So how do we protect ourselves? How do we protect the field workers, including your family members? Then how do we protect the public, the organisms we are playing with? In case you are a lab that you are testing Marburg, you are testing Ebola, how do you make sure that you are testing, you are putting in procedures and controls such that these organisms are not released into the environment? How do you make sure that these organisms you are working with, nobody comes in to steal it? If you are working on anthrax, how do you make sure that nobody picks it out to go and use it for something else? So once we know these things, that is the purpose for which we do biorisk management. One, for we the lab people, those in the field, the public, and then the environment. So that is the purpose for which we do biorisk management. So we have talked about the definitions, we have talked about how we implement the key things we need to implement. Now, what is the strategy? How do we do this? I know that Greater Accra, you went through risk assessment. The major strategy for us to be able to manage biorisk, the first thing is you need to describe the work activities. So at the pre-analytical state, what are all the activities we perform? You need to list them. Once you list these activities, you should be able to identify the hazards that comes with it. The hazards would have to do with the biosafety. Then the threats would have to do with the biosecurity. You have to list all of these. Then you need to determine the risk. What are these risks associated with all the things you are talking about? When you are able to do from point 1 to point, excuse me, I'm coming. From point 1 to point 3, we call it risk characterization. You are characterizing your risk. And that is the first strategy you need to do. After characterizing, you need to do risk evaluation. And what is the risk evaluation? Now you have determined the risk. You need to decide whether this risk is acceptable or not acceptable. If it is acceptable, you continue with the work you are doing. If it is not acceptable, you need to stop and evaluate and start the whole process again. When you do that, the risk characterization and then the risk evaluation, when you put these two assessments together, we call it the risk assessment. So risk assessment would start from you identifying your works, the hazards and threats, determining the risks that are associated with them, and then deciding whether the risk is acceptable or not acceptable. When you put these two together, risk characterization and evaluation, then we say that you are doing what? Risk assessment. The next strategy you need to find out, is that you need to prepare your risk. If it is no, you have to prepare your risk control measures. You have to implement your control measures and what we call that the mitigation measures. You need to put in all these things. If you are able to do all of this, this is the strategy that you use to make sure that you are having a very good risk management in your facility. Now we are finished with our biorisk definitions and how to use the strategies and things. We want to know our potential risks that we are working with, and that is one of our objectives. These are things we already know, so I won't belabor the point. When you get the slides, you have them. So we are talking about all the organisms, their toxins and their allergies, which are. So we, knowing these biological materials, we classify them. And this classification, there are so many ways of classifying it, but the most common ones are based on these criteria. We classify these agents according to their pathogenicity. We all understand, we are lab people, so that we can finish early. The infectious dose, the mode of transmission, the host range, whether there is availability of a treatment or preventive measures. based on these criteria, we have these 4 groups of biological agents we deal with. There is group 1. These ones, they cause low infection to the individual and then the community. The risk is very low. You move to risk group 2, moderate risk to the individual and low risk to the community. Please, we can read the details when we get it so that we can finish early. Then the group 3, the risk associated here is high to the individual and low to the community. And then the risk group 4 are the high and the high individual, high risk community. So for the last group, these are the areas of the Ebolas, the VHFs, the viral hemorrhagic fevers. The risk group 3, we have so many examples there. We will talk about that when we are discussing. So on this note, I want to hear a few voices. Or for the sake of time, we would continue. When you get that, you just have to review and see whether you have understood what I mean by biorisk, biosafety, biosecurity. Or solo, you want us to do that? I wanted to find out whether I am clear enough in my...
I think the participant wants you to finish. Then, so what we will do is that we'll come back to this slide.
I hear you.
Yes.
Okay. So now we know the agents. These agents, where do we work with them? Which levels do we work with them? And therefore, that will bring us to the biosafety levels. There are 4 levels we are talking about here. And all these 4 levels are based on the agents I've described. The biosafety level 1, these are the basic levels of labs that we can think of. The 2 are the levels of lab that you and I are working in. But when we are done, you ask yourself, the level you are, is it where you are supposed to be? Or we should take you to a level 1 because of the things you have in there. For the level 3, is everything we have said from 1 to 3, including the fact that you need to have a okay, I'll take it one by one and then we'll talk about it. Then the 4 is the maximum containment. The level 3, we'll discuss that. So this, you should have personnel who have training and then they can handle the agents that we are going to talk about. So we want to take the levels one by one. So if you remember, in my definition of biosafety, I talked about practices, controls, and technologies. We want to look at the levels in this way. So the practices will include our normal standard microbial practices. That is the practices we do. So for a level 1 lab, if you take the lab itself, that level 1 lab, we are saying that should have access control. So please take note, even a level 1 lab, it says access should be limited or restricted. It should be clean. It should be tidy. Even level 1, it should have a biohazard sign. As I'm describing, you ask yourself, do I have all these things? Because the purpose for some of these are CPDs is to help us improve upon what we have. These ones we don't do. If we are doing it, then we need to. So in the lab, you're not supposed to eat, drink. The working surfaces, you should easily be able to disinfect, even level 1. So if level 2, where you and I should be, we'll see whether you're able to do that. If you are using normal tables that we can't easily disinfect, your policies should include hand handling of sharps and then the attire. We have to use PPE. In the long and short is that we have to use PPE. The one important thing is that if you have long hair, please don't restrict it to only the women. Some men nowadays are growing long beards and long hair. We have to make sure that we tie them at our back. And then preferably no jewels. And these are things that we know already. Still on the practices. When you are working, no oral pipetting. Hand washing, you have to do that. You have to avoid creating of aerosols. And then you have to label all your everything, not only cultures. Still on practices, disposal. Please, even level 1, we are saying that you should incinerate or autoclave all your infectious waste materials. How much more where we are? We have to make sure that we are autoclaving these things. And then we should leave our infectious items for no other person to handle. So as you create the infectious substances, please make sure that you handle them before you move. You don't leave it for another person. Now we are finished with the practices in a level 1. We want to talk about the safety equipment. What kind of equipment do you need in terms of safety for a level 1 lab? For level 1, we are saying that you don't need any special equipment. And the equipment for safety in the lab is the biological safety cabinet. These are the equipment we are talking about. All the equipment you need is your normal PPEs in a level 1 lab. Still on the facility, we are finished with the safety equipment. We are coming to the structure itself. The lab should have doors for access control. Each lab should contain a sink for hand washing, and it should be designed in such a way. So we would go into details. There's another session of laboratory design. When we get there, we'll talk about it. For a level 1, we don't want carpets, we don't want rugs in the lab. So then this brings to mind those of us who have curtains that are cloth in our labs. We have to think about it. This one we'll discuss later. On the facility, your bench tops, I've talked about that. The furniture, what kind of furniture do we have? Is it the one that is supporting our backs ergonomically? Or the one that I met in one of the labs where the chair is already slanted? So perpetually, you are going to bend to be observing microscopes, and this is not good. So even level 1, you're talking about ergonomical chairs. So we have finished with how to describe a level 1 lab. We described it in the area of practices, the safety equipment you need, and then the structure of the building. We are moving on to level 2. Level 2 is everything I've said in a level 1 lab, including these ones. So for a level 2, the additionals are that the people who are working in the lab, you have to have appropriate immunization or tests. Any test that they handle, if there's immunization that has to be done, they need to have them. So if you are working with hepatitis, and definitely the samples we handle, you don't know what is inside. So it means that you have to have immunization on that. Those of us who are in the reference lab, we handle measles, we handle yellow fever, all these things we need to be vaccinated against. So these are the things that we have to know. And then we need to make sure that when you are coming to work in such labs, your baseline sample or serum should be taken note of. So you should go through a series of tests to make sure that you are coming in clean. And then if you, whatever you have, we know, so that you either don't introduce it to your clients or you don't also pick hospital-acquired infection or laboratory-acquired infection. It is very, very important. All our procedures, we need to have them in our SOPs. We have to have manuals on all these things that we do. The practices are not supposed to be in somebody's head. We need to put them down. Still on the practices, the shafts we don't have to use rain needles. These are things that we know, so I can go. We also want to reduce the use of glasses. If we can use plasticware. So if you have realized, most of our sample collection tubes are now coming in the form of plastics, which is very good. We need to report spills and accidents. We have to encourage the culture of reporting of incidents. This is very good because it helps us to know where our issues are. And this gives us also the opportunity to have training needs in our labs. We have talked about that. So for safety equipment, we are saying that we all don't do pipetting with mouth. So you need to have a pipetting aid, whether electronic or that bulb type, fine. We need to have, if possible, for those of us who are doing bacteriology, plastic loops. If you don't have a plastic loops, can you have electronic transfer loops, or what we call the loop incinerator, the ones that I think the reference lab we have one. Our labs are so enclosed, and we are using Bunsen burner, where we are creating more aerosols. These are things as lab heads and lab professionals we need to work on. We have to move from the Bunsen burners to either a loop incinerator or disposable loops. For a safety cabinet, we need class 1 or class 2. We'll go into details when we are doing the design to know what is a class 1 biosafety cabinet or a class 2 biosafety cabinet. We'll take those ones in our third discussions. So these are the equipment you need. So as I said, level 2 labs are all medical labs where you and I are working. So if you are working in a lab and these things are not there, we need to up our game as lab professionals. But some of us, I always ask, the labs we are even working in are just like my palm. If you bring these cabinets, where are we putting them? So these are things we need to work on as we grow in the profession. Then PPEs. But let me state here that the PPEs, as you move along the levels of lab, the types of use or the different types, the safetiness or the usage increases. So where even a level 1, you might not use certain types. When you go to a level 2, the PPE types changes as well, and that you need to take note. The facility, the building. For a level 2 lab, you need to have autoclave. I've talked about that. There should be an eye wash station. You have to have lockable doors. And all these are things that when we are building the labs, but we'll do the details in the design. So I will just have to rush. For a level 3, all the things that I've talked about in 1 and 2, plus these ones. A level 3 lab, you have to have a controlled access. The laboratory doors are kept when experiments are in progress. Again, the baseline serum, we need to do it. Assess the people who are coming to do that. We need to know what kind of disease they have and what they don't have. We have to manipulate everything that we do in that lab, the level 3 lab, in a biosafety cabinet. You can't open tubes outside. You cannot be doing your centrifuging and things outside. They have to be done. All manipulations have to be done in the biological safety cabinet. These are the practices we are talking about. The safety cabinet, we need a class 2 or class 3. For the level 2, we said we need a class 1 or 2. For 3, a class 2 or class 3 would be okay. The PPEs, against, as I said, we have seen that the types are changing. Respiratory protection and all of that. The facility, how should it look like? As I said, we'll also go into the details when we are doing the design. You should have it such that you have a physical separation from access corridors. So it is not the kind of labs you and I have. You should have a self-closing double doors. You should have a changing room. The interior surfaces and the walls, the ceiling, everything should be you should easily clean it and decontaminate. So it is not a type of lab where you have emotional paints in there. It should be such that when there is a decontamination, you can easily do that. All windows in that laboratory are closed and sealed. So it is not a lab where you say, let me create a window. No, they are closed and sealed. You need a negative airflow. And you have to use special exhaust air ventilation. So you have to know or understand what negative air. Normally, when I'm doing this physically, I ask, you need to understand what negative air flow and positive airflow is. These are things that you need to understand. Let's progress. So now you have the 4, everything from 1 to 3, including these ones. You should have a changing room before entering. You should shower on exit. These are practices. All materials decontaminated on exit from the facility. The equipment is decontaminated routinely. There should be a logbook in a form, either electronic or manual. And these are things we do even for in the 2, but we are stressing on here because for this one, it's a must. You sign in, indicate the date and time that you entered and you exit. This one is key. That is why we are mentioning it. The others we do, but I didn't stress on that. For the equipment, the safety equipment, a class 3 or class 1 or 2 with combination of a full body suit, air supplied positive pressure. So this is where the positive pressure is mentioned. Please, you would help me to differentiate between the 2. Don't ask me. Please find out what these 2 meanings are. It is good for us to understand. For the facilities, again, how the structure should be. It should be separated from the building, or it should be in an isolated zone. It is not built around where a lot of human activities are done. And then you should have a dedicated supply of exhaust vacuum decontamination systems. Even the same with the 3, the waste that we pour in our sink, it should be such that as you pour the waste, there's a decontamination system attached to that waste, and then it is decontaminated before it flows to wherever it goes. So this table gives us a summary of all that I have said with biosafety levels. Normally, when we describe these levels, when I started, I said the risk groups helps us to know the levels. But let me stress here that it doesn't also automatically work like that. Every activity that we do, we have to do what we call the risk assessment. You can have a risk group 1 agent, but then because of the activities you are going to do with it, you would have to move it to a level 2 lab and work with it. So as you see the table like this, it is not automatic. You can have a risk group 2 organism, but then because the activities you are going to do would increase a lot of risk, you would have to move it to a level 3 lab and vice versa. So it is based on the risk assessment you do to the organism that would help you to determine the level you work with. So on the face of it, you will say that risk group 1 is done in a level 1 lab, but it doesn't work like that. You need to do what we call the risk assessment, which I know Greater Accra team, you were able to get that training from Mr. Kutami. Let me ask, how many of our labs in Ghana are level 3? Currently, we have Noguchi, 1 in Noguchi, we have 1 in KCCR. Then during the COVID time, we were supplied with 4 containerized P3 labs. 1 is in Central Region, specifically at Ankafo. 1 is in Sunyane Teaching Hospital. 1 is in Huahua Regional Hospital. Then 1 is at Kolibu under the reference lab. So these are the additions of our level 3 labs that we have on the human side. For the animal side, we have 3. They are also containerized, like the additional ones they added during COVID for the humans. So for the animal side, there's 1 in Takrade, 1 in Accra, and 1 in Pont-Tamale. So these are the additional information that I want you to in terms of the levels of lab. For level 2 labs, as I have said, it's all the medical labs. Wherever we do medical, we are supposed to be a level 2 lab. So with the things I described, you should ask yourself, do I have what it takes to be in that level? If I don't, how do I improve upon it? As I always say, it is not a fight between you and your managers, but gradual collaboration, jojo, advocacy, we will get there. These are the key messages that I want you to know. Biosafety, biosecurity, biorisk, all these are common terms that relate and support each other. We have to use the AMP. This is a simple but powerful tool. And what is the AMP? Assessment, mitigation, and performance. It is a simple but a powerful tool to manage biorisk. Implementing a comprehensive biorisk management system is critical to reduce both safety and security risk that is associated with the agents that we are all working with. And then some of the key factors for establishing and implementing a successful biorisk would always have to include the top management and then continual improvement. And although there are several classifications for the organisms that we talked about, they are all based on the notion that some organisms are more hazardous than others. And then determining the risk group of a biological agent is part of the biosafety risk assessment, and it helps us to assign the correct level of containment for the work we do. And there are 4 levels of biosafety labs on the basis of infectiousness of the agent. These are the resources that when you get this slide, you can quickly would look at, and then it will help you to also abreast yourself with the things we have talked about this evening. Thank you very much.
Thank you very much, Dr. Boateng. I think so far this is the introduction. It's good it is brief so that we can assimilate what you've taught. So from all that you presented on, what I got from it is that biorisk management should be a culture involving everybody, including all workers within the laboratory. And I think one of the salient things you've mentioned is about background checks of people who work in the lab. And we've had situations where we have to send information to international bodies about our members, and I think it's something we need to consider. So these are one of the things that we'll look at as the next steps, and as experts in the area, we'll consult you to help us develop guidelines on that and how to implement this. And so I don't know whether you want us to go back to the slide 16 or we should allow for...
We should allow for questions, and then if there's any clarification.
Okay, thank you.
Okay.
Thank you. Dr. DJC. All right. So the floor is open now for us to ask questions. Elizabeth, are you still around to ask your question? Okay, so anyone who wants to ask a question can raise up his or her hands, on mute, and ask the question, please.
The way we cannot hear them, is it that maybe you have muted all of them?
That's what I did initially, but I've corrected that now.
Please, we are all around.
Okay, Naomi, you can ask your question and contribute too.
Sorry, I don't have a question, but I just wanted to say if we are not on mute, we cannot hear you loud and clear. Thank you.
Hey, Dr. Botin, so let me look in the chat. I think this question has already been answered. There's a question here from Kofi. Kofi, who is asking, are there any BSL-4 laboratories in Ghana?
No, please. We don't have any in Ghana. We only have 1, 2, 3.
Okay. The second question is that, please, Doc, what are the local ways of handling laboratory waste in the absence of an incinerator?
What does the person mean by local waste? Local ways of handling?
Local ways of handling laboratory waste. I think.
So Solo, can I come in?
Very well.
Yeah, I think the person wants to know whether there are alternatives. For example, if you don't have your biosafety cabinet, what do you call it? Your autoclave, as it were, the dirty autoclave to, autoclave, let's say your culture plates before you send them out. Are there alternatives?
Okay, so normally when I'm doing this, I stress on the things that normally we will not handle, with the assumption that we all know how to do disinfection, using of our bleaches and all of that. But if you realize, how well can you use bleach to disinfect or reduce the viral load or the bacterial load of the things we handle? So that is why we would always stress on that. But then the other ways are there, depending on the waste load also. So if the waste load is very high, how well can you use the disinfection or any of the others to do? The best is to have them carry them put in autoclave, where you are likely to bring it to almost zero if your autoclave is working very well. So the other ways, but we look at it from the optimum, because looking at the work we do in our level 2 labs, we generate a lot of infectious waste. But how well do we do it? And waste management itself is a whole other area that, as a lab professionals, if we haven't even looked at it, we need to. It's a big issue where I always ask that we do the separations in our labs. Meanwhile, when our cleaners are taking these samples out,
by the window side.
They mix them again for us. We do the segregation. We outlet or source out our waste disposal. Can we get our colleague who is talking to mute?
Joshua, please, can you mute yourself?
Thank you.
Joshua.
So waste management is a big issue. These are areas that we are also looking at. We segregate them, but then I've been to most of our hospitals, and then they end up outside the facilities and they are mixed again, because most of the waste management is done by somebody else who doesn't understand the segregation you have done. So we, again, for biosafety, biosecurity, we need to know where our waste ends. But this evening, we are just on the introduction. So waste management is a whole another topic that we have to look at. Thank you.
Thank you. So in talking about waste management, I think it also borders on biosecurity management. In a particular hospital, what I realized is that when waste is taken from the work area and sent to the holding bay, the people scavenge. They go through the waste to the extent that sometimes you see them pouring out urine from containers and recycling them, getting people to buy it. And you see trucks coming to buy some of these things. And sometimes you wonder, where are these things going to? Does it not come back to the society? And are they not these containers that people produce creams and put inside and we buy? And so I think it's also important as professionals, we look at how we can destroy these things before it gets to the areas, especially the plastic waste, how we can modify them to the extent that they cannot be used or recycled and used directly for the public consumption.
So thank you very much, Solo. So that is where, if you are using an autoclave, it comes out and then this rubber is even destroyed because of the heat. Again, you have reduced the load. So even if somebody is going to play with it, it is reduced. That's why I was asking the other methods we are trying to suggest. How well can they reduce the workload? The idea is that you have infectious agents you are working with. How do you reduce these things from coming into the public? So you have to decide that, what can I do? That is why I say we go for the optimal. We need to have waste autoclaves in our labs. All of us, especially those of us who are doing microbiology, then we don't even have any option, because for us, we are producing live organisms, which can easily spread. So we need to look at it. And then again, we need to be part of our management in our hospitals to see that the segregation we do, where do we take them? Where do they end? As I said, I've been to most hospitals and it is being contracted to, I think, Zoom Lion also. They come and they put all of these things together. As you said, the holding rooms. It is in an open space that nobody takes care of. One hospital, the dustbins were just in front of the hospital and they were full with crows. And so these are things, when we are talking about safety, we need to extend it from our labs to the environment, because we are protecting the environment. Thank you.
Thank you very much. There's a question here saying that, please, what about vaccination? Level 2 labs are supposed to be vaccinated. Why not level 1 labs too? Some samples are taken at level 1 labs and sent to level 2 labs if the patient cannot travel.
Can the person define, based on what I have described, can the person help us? Though it is in the chat, can the person describe the level 1 lab?
All right, so Stella, you can unmute and
can
contribute.
Unmute and then contribute
so that we can understand you very well.
Yeah.
Okay, thank you. The question is, where level 1 labs, some of them don't do measles test and all that. So they take the sample and send it to level 2 lab
So
for
please,
it to be tested. But
can
you were saying level.
So sorry to cut you. From what I've said, what is a level 1 lab? With the understanding you have this evening. What kind of lab are you describing? Because in the table
for the level 1 lab, they don't perform measles tests and all that.
Is that the understanding you got?
Well, maybe
what do they do?
Level 1
level
lab.
1 lab, what do they do?
Hello, Doc. Can I contribute?
Oh,
yes,
okay,
I want her to appreciate the where she's coming from, so that she will know that her lab is not supposed to be a level 1 lab.
Yeah, I want to assist my sister a bit.
Yes, please assist her for me. Thank you. She
Doc,
has understood.
Yeah, so Doc, I think from your submission, and even with newer conventions in terms of classification of labs, apparently you would have to really do a thorough risk analysis to see exactly what you handle, even if you don't process it and you're receiving the samples for transportation. At the end of the day, there's a possibility that you could have an exposure in between somewhere. So definitely, you look at the level of risk that you are exposed to in terms of the samples, and then you'll be able to classify. So even the classification is not static. It can actually vary from time to time, depending on the procedures, the lab use, and all sort of things that happen. So in my sister's case, if she has to, take a specimen that belongs to biosafety level 2, then definitely at that point in time, the grading has actually shifted. So she has to also make sure that all the protocols that are in place in a biosafety level 2, I mean, even if it has to do with the sample handling, she has to make sure that they are enforced. Other than that, there's a possibility that somebody could also pick up an infection from there. Thank you.
Thank you very much. So we are here as all of us are professionals. So my sister, I'm happy you were able to know that where you are. I'm sure that you are looking at the facilities you have and say, me, I'm at a level 1. All the labs we are working in are supposed to be a level 2. The level 1 labs I'm describing here, our teaching hospitals, you saw the kind of the labs you came from, your secondary school labs. Our university labs that are just for normal, small research. You go and sit and they do demonstration for you to see. These are level 1 labs. But for level 2 labs, all our primary health services, our research, our diagnostic labs, all of us are level 2. The fact that we don't have the structures which we have to work on does not mean that we have to lower the standards. For some of the practices, we can improve upon it. It's the structure that is difficult. But then this vaccination, you are supposed to be vaccinated. And I'm happy with what my brother said. Now, and I even said that it is not static as you see in this table. Depending on what you are going to do, you have to do what we call the risk assessment. And then it will move the practices, the procedures, the level of lab will change. So please, let's take note of that so that we don't equate that because it is a risk group 1 organism, risk level 1 lab will do that. Thank you.
All right. So I think we'll now move to Darren. Then we'll go back to the chat later. Thank you. Darren, and any other person who want to ask questions.
Yeah, so hello.
Kindly go ahead.
Okay, Dr. Watson, thanks for the nice and wonderful presentation. Mine is not a question, it's a suggestion in addition to the vaccination that we've talked about. Most of us work in hospitals or even health centers, and the truth is that the vaccines that are given to children are the same vaccines that adults can take. So with respect to yellow fever, measles, and so on and so forth. So once we work within the health sector and we are getting this exposure with respect to biorisk management, it's prudent on ourselves that wherever we find ourselves, we'll be able to get some of the vaccines from the community health nurses, the enrolled nurses, or the disease control officers, so that at least based on the work that we'll do, we'll get ourselves immune, and then the requirements that Dr. Boateng has said, we'll be able to fulfill them. Thank you.
Thank you, Darren.
Elizabeth, your hand is still raised. Is it a mistake, or if you're available, ask your question. If not, we'll take it as you are not following us. Okay, so there's also a presentation. Okay, Edward, kindly ask your question.
Yeah, hello. So I don't know. I want to seek some clarification. Infrastructure of the lab. Is it supposed to be part of the element you look out for classifying a particular lab? So if it is, then then I don't think the classification should be complete, right? Because I understand, yeah, like you mentioned, some of the processes we can start doing it even though the infrastructure is not there. So I want to know what role does the infrastructure plays in classifying a particular lab in terms of the levels.
Thank you. So is that Edward?
Yes.
Yes. So normally when a question comes to me, I try for all of us to appreciate together. So I throw it back to you. So
no, I'm listening to you. I need clarification, so I'm not going to.
You need clarification, so you don't want to be involved there. When I get you involved, then it makes you to appreciate where I'm coming from. So that it's not like Dr. Boateng said, but we are all agreeing to get the answers. So
no, I want to hold you responsible so that if I have any problem, I can always contact you.
You are good. Yes. So the levels, as I said, it is based on 3 key things: the practices, the facility, the design, what goes into the building, that is the facility, so the secondary barriers. Then the safety equipment, as you can see on the screen in the summary. So there are certain things that, in terms of the building, as you have asked, the infrastructure, the building itself. When you are building a level 2 lab, it is a must.
Okay, please, sorry to cut you. The infrastructure here I meant was inclusive of all those equipment and facilities that makes the classification, like the safety cabinets, the close box, and all those things, including the buildings. Yes.
Okay. So then let me get your question again. What exactly is your problem?
So my problem or worry is based on the classification, right? If you take our labs right now, those infrastructure are not there. Some of the labs are performing some of the processes that you spoke about, but they are limited. So the question is, they have half of the things to make a particular lab to be classified, like say level 1, level 2, level 3. And they don't have some of the things to fully classify it. So in this case, I don't know whether I'm making sense with what I'm trying to say.
Yeah, so you're really making sense.
Because it's not really complete. So let's say level 2 lab doesn't have, most of them doesn't have the fuse chamber and all those things. That makes the level 2 lab fully complete to be classified as such.
So, yes, I get you. So Eddie, if you listen to me, I said that all our diagnostic labs, including where you work, where I work, are supposed to be. I use the suppose. Meaning that if we should go and do assessment, it's not that we are now going to classify and move you to one. You are already working on those organisms. So it is up to us leaders in our various institutions to up it to where it's supposed to be. If we happen to be working with HEFRA, by now we should be closing most of our public health labs.
Sure.
Because it is a must to have them. It's not that because of the way they have been built, so we are now going to negotiate. No. We need to have them, but we don't have them. So we need to know some of these things. And then if you happen to be, and it's a responsibility of all of us, you are consulted to, I know this will bring another discussion, but don't let us go there, to help in the building of a facility. As Chief Papa will say, now a lot of Agenda 111 buildings are being put up. How many of us have taken the pains to go and see the lab they are building? What will go into? You will tell me that you're not a politician. Yes. How do we engage our leaders? I always say that there's a lab that I recently visited. It was commissioned by our Adgon Minister of Health. Sorry, that lab is just small like my palm. I was talking up to it, and somebody said it is not only that place. All those types of public, polyclinics, the lab is just like that. It's just small. So in terms of safety, it's zero. Again, I am talking from the leadership position. What structure have I put down that if somebody is going to build a lab for us, they have to look at and make sure that they have the eye wash stations and all the things I'm talking about? It is a must that we have them. So if you happen to be part of any building that there's a lab, these are the things we need to know and make sure that we contribute. As I always say, you would talk because you are not fully part of management, which we are working on. You say that they will listen, but you make your case. That they will come to you and say, Akwa we can NINT. Thank you.
All right, Dr. Francis Kwachi Enchi.
Yeah, thank you so much, Dr. Solomon. And then I want to also thank Dr. Gifty for such a wonderful presentation. What I wanted to find out was my understanding of the negative flow and the positive flow. So if Doc would listen to me and then ascertain it for me, that would be great. So my understanding of the negative flow is that room, the pressure of air in the room is lower than that of the outside air. And so when you open it, no hazardous waste in terms of aerosols or whatever will seep outside that containment for the negative flow. And then that of the positive flow, it means that you have the pressure of air in the containment higher than that of the outside, so that, for example, if you are keeping, let's say, an immunocompromised person in there, you don't have air flowing from outside into the room, which possibly can bring in infectious agent to put the patient at risk. I don't know whether that is correct. If Doc can confirm it for me. Thank you.
What?
Oh, forgive me. I've been talking plenty. No, I'm muted. Forgive me. Yes. So if I heard you right, you are saying that for the negative air pressure, what does it do? Can you say it again?
Okay, let me come in again. So what I'm saying is that I just wanted you to confirm what I have, so that if it is not right, it will be taken out of my head. So for the negative flow, what I understand is that the air inside the room, the air pressure there is lower than that of the surrounding environment. So when you open the room, you don't have air from that containment going outside the room so that you don't contaminate outside. And then that of the positive flow, the air pressure in the room is higher than that of the one outside. So when, for example, you have an immunocompromised patient in there and you open the room, you don't have air flowing from outside into the room to pose a hazard or a risk to the patient in there. That is my understanding. Thank you.
Yes, so that is exactly what you have explained. So the example you gave, an ICU room is for the positive, and then the negative could be our P3 lab rooms, where you are making sure that you are not expelling the organisms you are working with outside. And then with the positive air pressure, you are not introducing organism also into the room because of the nature of the people we put there. So you've said it right, and that is correct. So these are things we need to understand. Thank you.
Thank you.
Thank you. Thank you. So MLS Eric Amwako is saying that, thank you for this insightful presentation. Please, I want to ask if it will be possible for a national guideline and policy that will ensure that all hospitals have incinerators to manage their waste generated in the laboratory or the hospital.
Okay, so I think these things are already in our IPC, and then our waste management policies. How many of us have them? You can easily get them online. These are policies that we have, but it is the implementation. So you and I have to make sure that we help the system to implement. They are already there. What we are trying to get is a manual for the lab, to get a biosafety, biosecurity manual where it will guide us. We are taking keynotes from the WHO one, so that as a country, what is it that we want to do? These are guidelines, meaning that you need to follow it and adapt it in your lab. But then the waste management is in our policy already. There's a waste management policy. Now when you Google, it can come out. It is the implementation and who is supervising what is left. Because the waste they even generate from our surgical and things are more than what we are. But then every item that we receive in the hospitals are classified as potentially hazardous. So we need to treat it like that. Thank you.
All right, thank you very much. So I'll skip one aspect of Dr. Chris Nkume's question. But the second question is that, what measures has reference lab put in place to track samples transported by public vehicles?
Okay, so these are things we are trying to manage now because we know it is there. But the challenge is that there are no guidelines guiding the things we do. Secondly, our sample referral system is done anyhow. We are working on that with the support of Global Fund to make sure that we get an integrated system. That integrated system will come along with guidelines. It will come along with a tracking system. It will come along with training. And so it is a gradual process we are taking. These are things that we are doing that are not correct. Even recently, myself, I needed to get samples from one of the regions to Accra. We couldn't have any alternative because these courier services were not there to help us. And so we have to use the transport system. But even if you are using the transport system, how do you educate the people who are transporting it in such a way that you can track, they do it in the way that we want it? Are they going to mess it up with the food, our clothing and all of that? These are the things that it's a hectic task, but we will start gradually and we will get there. And we are not doing this alone as public health. We are doing it together with everyone. Safety is the business of all of us. And so that we don't say that it is public health. So we restrict to that. We are all sending samples. And so we have to be mindful that we need to support ourselves to get it right. Thank you.
All right. So Rose Tete Ansah is asking, how should we handle liquid waste such as waste from hematology and chemistry analyzers. Let me add up another one. There's another one that is suggesting that Gamls takes this issue of waste management to another level and try to engage policymakers for all members have been well educated. I think well noted.
Okay, thank you. So if I understand the question, I'm sure he's looking at, is it the blood product as the liquid waste or the other liquid waste that we generate? So if it is the blood that he's looking at it as a liquid waste, here again, the best way to reduce the infectious dose is to incinerate some of these things. We do that, but they are moving out of your lab. So the first thing is to autoclave. That is, I keep on saying, you keep them in a biohazard bag. These are things we don't do, so we find it as strange. You keep them in a biohazard bag that is autoclavable. You put them in your autoclave to reduce the waste. What we forget is that sometimes we want to move it straight to the incinerator. It is a cleaner who is moving it. Along that path from your lab to the incinerator, do you know what goes on there? As Dr. Kwashi said, we sometimes even keep them in our holding rooms where you see people coming to play with them. That is why your mentality, your mindset should be such that whatever waste I'm generating that is infectious, I need to reduce the amount of risk before it moves out of the lab. And the best way is to use the autoclave to reduce that waste. If it is the normal reagents that have come into contact with blood and things, normally what we do is that you put a bleach in a container, what we normally do, and we discard these things in a bleach before we pour into, we have a sluice room where we have a sink. That is a public health lab anyway. So these are things we need to consider when we are building the lab. We pour it into that sink. There is a, what do you call it, a heater and things connected to it, which when we flash, it is decontaminated before it moves out. These things should be part of our labs, but unfortunately, they are not there because those who are helping us build the lab don't have this safetiness in their mind. So it is up to us as lab professionals to educate ourselves in these areas so that we can contribute to the new labs that are being built. Thank you.
All right, thank you very much. And so there are no questions in the chat box. If there are no other contributions, Michael, is there anything you want to contribute? Okay, so I think when we go to the Ministry of Health website, there are good policies on waste management and other safety policies by the Ministry of Health. And so let's go to the website, download these policies, and use this as a tool to advocate at our facilities, to tell our managers that even the employer, the Ministry of Health, is saying that we should have these strategies in our workplace. Even recently, they have launched a national IPC strategy. The document is not yet out though, but the Ministry of Health has launched that. Let's get this document and use it as a tool to advocate at the facility level to ensure that the right safety measures and security measures are put in place to protect the public and ourselves. And so we are grateful for your attendance today. And the slides will be made available after all the presentations. So be assured that you get them.
Hello.
Dr. Boateng.
Hello.
Okay. All right. Kindly go ahead.
Dr. Boateng, I'll be happy to help me understand. How do we keep the baseline sample
if you can just introduce yourself, let's know who is speaking and you ask your question, please.
Okay, I'm Thomas Dankwa.
All right, kindly go ahead.
Okay, I would like to know, how do we keep the baseline samples for our staff, and for how long should this baseline samples be kept, and then how regular should we also keep testing our staff in order to make sure that they have not contracted anything from the work they are doing?
Okay, thank you very much. So I think there's one thing that some of us were asked to do when we were joining the Ghana Health Service, but we didn't know that this was for the purpose. So they asked you to go and do a medical screening. So when you are entering into the system, you need to do that. And this documentation is kept on your file, not the human resource who keeps this. You should have it in your file, in your lab. The frequency of testing depends on the nature of work you are doing in the lab and then the workload. And that has to be defined by the analysis you have done, the risk assessment you've checked. So it is lab dependent. So if you are a type of lab that it takes you a long time to do one test and then you are not doing anything again, the frequency that you do this serum check will not be like a lab that is constantly into a very big workload. So that definition and frequency should be determined by a committee, what we normally will call a safety committee in the lab, which will be led by the safety manager plus your quality managers and then all top management. So you define it based on the risk assessment you've done and knowing the risk that is associated with in your facility and how often. It will also, okay, that is on that. I was zooming into the vaccination, but we won't go there. So that is what I will say for now. Thank you.
Thank you. I think we would be ending as we don't have any questions. And so Dr. Boateng will be asking for your last words and what should be our expectation for tomorrow.
Yeah, I just want to thank everyone for making this evening's meeting a success. And thank you for the insightful questions you asked and then the contributions. It shows that we are all active. My last word would be on the point that somebody recommended, which has always been my heartbeat, the waste we generate. Where do we leave them? Because all that I've discussed on safety, if we are not managing our waste well, and I didn't talk much about it here because it is the introduction to biorisk. We need to take this up as leaders and then as also our association level and see how best. And then everybody, you are generating the waste. How do you reduce the risk associated with it before it leaves our lab? It is very, very key. Every day somebody will say that even the autoclave I need to do my microbiology, I'm not getting, you are talking about waste. But it is possible, it is doable. We need to work on that. On that note, I want to thank you. And tomorrow at the same time, we would, my suggestion, I think I will be traveling, but we'll see how it goes. I was trying to combine the rest of the two together. If we are able to finish the first one, there's enough time, but otherwise we'll keep it as it is. But I hope that tomorrow too, it will be very insightful because I'll be getting a lot of support from everyone. Thank you very much and good evening.
All right, thank you very much. So Dr. Boateng, to add to your suggestion that we should be interested in the type of facilities built for us. We as a professional body have attempted severally to get people like you to contribute to the Agenda 111 project. But because of the political nature of the project, government is not trying to open its doors for us to make inputs into it. And so let's try at high level meetings, let them know that they are rather creating a hazard for professionals and the public. So they should open their doors for the professionals to make inputs.
Okay, thank you very much. But I also will stress that we do that at our facility levels. Well, if you are within the facility, you know they are building it for you. Please, we get interest because at the top, I must confess that I don't even know where some of them are being built because they don't engage us. But they move straight to where the facility will be. So if you are there and you hear that they are building one for you, please draw closer to your med soup who you can talk to and say that you want to make a little bit. I know it is difficult, but it is doable. Thank you.
All right, thank you very much. Dr. Aiku, are you around?
Yes, I'm around.
Any announcements for us? Anything we should know?
Not really. I hope we'll close early so that people go and watch their football match. Yeah, so far so good. So far so good.
Thank you very much.
Yeah.
So on that football note, we are grateful to Dr. Boateng for sharing his knowledge with us and for us also making time to listen to her and contribute to the discussion. I think it's important that we take the little things she has mentioned. It is important that we document processes, procedures in our labs, and also engage our management on some of the things we require in our labs. Let us take these little steps so that management will know that the things she taught us or the things we advocate for as professionals are things that the culture of the organization has to also embrace. So we thank you, and we would encourage us to go back, watch the videos, share them, and like the Gamls TV. Thank you very much, and we wish the Black Stars a success in the game against the Central African Republic. Thank you very much. So see you tomorrow.
Thank you, and good evening to everyone.
Thank you.
Bye.
Thank you.
Thank you.
Thank you very much.
Thank you
very much.
Oh, I've looked for you. I didn't see you.
How far with the strike? Are we going?
Follow all the directives of the union.
We are going. We are going. Let's get serious. We are going.
Okay. We are going.
Whatever
We are going.
directive,
We are
whatever
all
the directive the union gives, kindly follow.
Let them hear our voice.